Good evening all. My study is does lung ultrasound guided ultrafiltration lead to better outcomes in acute kidney injury requiring intermittent haemodialysis, a randomized controlled trial. The burden of acute kidney injury and related mortality is increasing across the world and in India, and correspondingly there is an increase in the acute kidney injury patients requiring renal replacement therapies. So, if the mortality percentages are further high if analyzed among AKI patients requiring dialysis. In these patients, intradialytic events like hypotension can impede the renal recovery and worsen multi-organ dysfunction. In the other hand, if inadequate fluid removal is there, it can lead to fluid overload, which is an independent predictor of mortality. There are studies on optimal solute clearance and timing of dialysis in AKI, whereas ultrafiltration per se is less studied. The usual determinants of ultrafiltration volume are clinical parameters which can be often imprecise, and the many objective methods, out of the many objective methods available, the most widely used and easily available one is lung ultrasound. So, lung ultrasound B-line score is a non-invasive, easily available, reproducible, easy to learn method to assess extravascular lung water. And it has been shown in maintenance hemodialysis patients that B-line score guided hemodialysis is associated with fewer intradialytic adverse events and better outcomes, but there is minimal data on AKI patients requiring hemodialysis. So, my primary objective is to compare the status of euvolemia, which was defined as a B-line score less than 5, based on clinical assessment versus lung ultrasound guided ultrafiltration among hemodynamically stable acute kidney injury patients requiring intermittent hemodialysis. And the secondary objective is to compare the incidence of adverse intradialytic events, which were defined as a fall in systolic blood pressure more than 20 millimeters of mercury of initial levels, fall in systolic blood pressure more than 10 millimeters associated with nausea, vomiting, cramping, headache, lightheadedness or chest pain, or need for any interventions like reduction in ultrafiltration or administration of fluids. So, this is a randomized single center, single blind parallel group study which was conducted from March 2022 to July 2023. All adult hemodynamically stable AKI patients planned for intermittent hemodialysis with a regular heparin protocol was screened for recruitment, and the exclusion criteria include decompensated liver disease, heart failure with reduced ejection fraction, any underlying lung pathology, patients on mechanical ventilation, systolic blood pressure less than 100 or on inotropic support, non-case of CKD stage 5 or patients received any dialysis session outside, and pregnancy also is there. Coming on to sample size, it was assumed that lung ultrasound may, guided ultrafiltration may attain euvolemia in an additional 40%, and calculated sample size was 74, and 101 patients were assessed for eligibility, and out of the 74 patients, 37 in control arm and 37 in intervention arm, there were no intradialytic deaths, and 37 patients in each arm were analyzed post dialysis. So, at enrollment, all patients will be having a dialysis prescription with ultrafiltration based on clinical judgment by a person who is not a part of the study. And after enrollment and consent, 28 site lung ultrasound B-line score is done for all patients. After that, patients are randomized into control arm and intervention arm, and in control arm the already prescribed dialysis ultrafiltration orders are followed. In intervention arm, a sliding scale based on B-line score is used to modify the ultrafiltration if needed, and a post dialysis lung ultrasound B-line score is done for all patients after 30 minutes of dialysis. So, the 28 site lung ultrasound was done by scanning 16 zones on the right hemithorax and 12 on the left hemithorax, and 1 point is given if there are 3 or more B lines on in one intercostal space, with the maximum score being 28. Before the study, training was done under radiology, and the intraclass correlation coefficient was found to be high. So, patients in both arms received a standard 3 to 4 hour dialysis prescription, and the B-line sliding scale, B-line score dependent sliding scale was, if the B-line score is less than 5, a maximum of 500 ml ultrafiltrate was kept. If it is between 5 to 15, 500 to 2 liter of ultrafiltration was kept, and if it is more than 15, 2 to 3 liter with a maximum ultrafiltrate not exceeding 13 ml per kg per hour was used. In the control group, ultrafiltration is changed only if there are any intradialytic adverse events during dialysis. So, appropriate statistical analysis was done. And coming on to the baseline characteristics, which was similar in terms of demographic, hemodynamic or laboratory parameters in both groups. And the etiological classification, patients in intervention group had more of glomerular disease. Like glomerular disease was comparatively more in the intervention group. So, the volume status before the first dialysis, it was shown that the median B-line score was close to euvolemia in the control arm, and in intervention arm there were some patients with B-line score more than 15, which may have tilted the median score to slightly higher than the control group. But the pre-dialysis B-line score less than 5, that is which was defined as euvolemia, the proportion of patients were similar in both arms. And the hemodynamics was also similar, though there was a difference in the B-line score, baseline B-line score. The clinical assessment based ultrafiltration prescribed was similar in both groups. All patients received similar dialysis parameters, and in the control group the final ultrafiltration was less than which was prescribed. So, B-line score guided ultrafiltration resulted in significant prescription changes in the intervention arm. A total of 26 patients in the intervention arm had planned changes in ultrafiltration based on B-line score, and 15 patients had decrease and 11 patients had increase in ultrafiltration in the intervention arm. These were the outcome parameters. The euvolemia, which was defined as B-line score less than 5, though numerically was more in intervention arm, was not statistically significant. But the intradialytic adverse events were more in the control arm compared to intervention arm, and the pre and post dialysis B-line score difference was also more in the intervention arm. Because the baseline B-line score was more in the intervention, a logistic regression was done, which also showed that the adverse events were still higher in the control arm. And the change in B-line score and ultrafiltration volume was also correlated better in the intervention arm. And these patients, all the patients received one session of dialysis, but a total of 61 dialysis sessions were followed up in the control arm and 59 sessions in the intervention arm. And out of that, in the control arm 23 intradialytic adverse events occurred, and in the intervention arm only 4 happened, and the 4 patients in the intervention arm, 2 received a change of ultrafiltration, that ultrafiltration was increased after the B-line score assessment, and 1 had already received a decreased ultrafiltration, and 1 did not receive any change in the ultrafiltration after B-line score. And the outcomes of AKI were similar in both arms, and the mortality was around 13 to 15%, but this study did not include any critically ill patients with AKI, so it is underpowered to comment on the outcomes or mortality. The strengths: this is a randomized controlled trial, and the participants were blinded, and the dialysis orders were given at bedside, and the dialysis technicians were also not aware whether it was a modified prescription, and an objective assessment of lung volume with B-line score was done. Limitations: many critically ill patients requiring hemodialysis were excluded, so this cannot be generalized as such, and despite randomization, the intervention arm had more glomerular diseases, which may be the cause for increased B-line score also. So, to conclude, lung ultrasound lead to significant prescription changes in the intervention arm. Less adverse intradialytic events were seen in the intervention arm, and lung ultrasound guided ultrafiltration may offer better patient safety profile, and this is underpowered to detect changes in mortality or hospital stay. This is some studies in maintenance hemodialysis which have shown that B-line score changes better associated with ultrafiltration volume than other parameters, and there were decreased episodes of heart failures and better echocardiographic parameters in the lung ultrasound guided groups, and they had intensification of hemodialysis also. Coming on to AKI, it was shown that 66% of patients who were clinically euvolemic and 46% who were clinically hypovolemic had moderate to severe lung congestion in lung ultrasound, and B-line score guided fluid administration did not show any difference in the outcomes, but there was a decrease in the cumulative 24-hour fluid that was administered in the ultrasound arm. Thank you.